This is Vermont Edition. I'm Michaela Lafrac. Taxes are due in a couple of weeks, as we talked about yesterday on the show. And as you look at your personal or your business expenses from the past year and budget for the next one, there's probably one cost in particular that stands out among all the rest: the cost of healthcare for yourself, your family, or your employees. This year, 2025, the average health insurance premium on the Vermont marketplace is more than 140% higher than the national average. For those of us who get health insurance through our employers, our contributions are the highest in the whole country. Last month, we started to tease out why. We aired an episode of the Vermont Public podcast, Brave Little State, that looks into a listener's question about the high cost of health insurance here. And we interviewed Vermont's chief healthcare advocate, Mike Fisher. Today, we'll continue to untangle the web that is health insurance and health care with the chair of the Green Mountain Care Board, Owen Foster. The organization he represents was established in 2011, and it's responsible for regulating health insurance rate increases and reviewing the budgets of Vermont's 14 hospitals. Governor Phil Scott appointed Owen Foster to the role in 2022. Formerly, he was a federal prosecutor involved in a number of high-profile healthcare-related cases. Owen, welcome to Vermont Edition.
Thanks, Michaela. Nice to be here.
Yeah, we're so glad to have you. And listeners, you can join our conversation as well. What questions do you have about the cost of healthcare and health insurance? You can give us a call at 800-639-2211 or send an email to vermontedition@vermontpublic.org. Owen, I'd love it if we could start with some recent news about this tentative settlement with the UVM Health Network. The hospital essentially exceeded its revenue limits in 2023 by about $80 million. And they say it's because they've been providing more care to sicker people. Not everyone agrees with that assessment. But under this new agreement, they'll pay settlement money to primary care providers and the insurer Blue Cross Blue Shield, and it'll restrict bonuses to hospital executives. This comes after months of closed-door meetings between the Green Mountain Care Board and the health network. How do you feel about where it ended up?
It hasn't ended up anywhere yet because it's a proposal that's under regulatory review. So I don't know where it will end up is the short answer. It's a different approach than what's happened in the past. In fiscal year 25, we looked at fiscal year 23 overages of $80 million and reduced every single dollar of it. A full 100% of what they went over was reduced in a rate reduction. In response to that decision, UVM made a number of service line cuts to sensitive services. And that was not a good formula for Vermont. It did reduce
closing dialysis clinics and other places around the state.
Correct. So this was an attempt and an approach to try and find a better path, which includes some really urgently needed critical money for independent non-hospital primary care providers that are really the linchpin of what we're trying to do in healthcare, but have been really severely strained financially. So this provides some bridge funding for them, and it also resolves allegations that Blue Cross was overcharged by UVM, and Blue Cross is in a really serious financial straits right now, so that money will help them. And by providing that money to Blue Cross Blue Shield, it will actually lower some of the price burden on commercial because Blue Cross will be looking to increase its reserves. And so this would be actually $12 million to help them with that.
Yeah, I want to get into the situation facing Blue Cross in just a moment. But first, under this tentative agreement, which as you just said, is still under review, the Green Mountain Care Board won't take action against UVM Health Network for exceeding its budget last year by, I think, about the same amount that it did in 2023, if I'm remembering correctly. So that means it did the same thing 2 years in a row, but it's only going to have to face repercussions for one of those years?
It's $53 million for fiscal year 24.
Okay.
And I don't...
So less than the previous.
Less than the previous year. And then also how it happened and why it happened is different. It's not like every time a hospital goes over budget, their prices are reduced by an equivalent amount of dollars.
Okay.
Last year, we reduced zero price on Northeastern Hospital for budget overage and for Porter. and Rutland was reduced by 50%, and UVM was reduced by 100. So it's not like it's automatically you're going to have your full price reduced. You look at why and what happened and the circumstances around it, and that sort of drives some of the decision. I wouldn't say it's without repercussion. I don't think UVM would either. They are having to write a check under their proposal for tens of millions of dollars. That's significant. Additionally, they would have an independent liaison working with them, hand in glove, trying to review their budget and their budget compliance and their representations to the board and the public. On top of that, they would be required to have a pretty extensive look at their operations to drive a longer-term path towards financial efficiency for the state.
Well, let's speak more about Blue Cross. It's Vermont's largest insurer. And we got an email ahead of today's show from a listener named Matthew in Alberg who wrote in to share his concerns about Blue Cross's financial prospects and the role of GMBC. Earlier this year, for folks who haven't been following this news, Blue Cross announced a significant deficit for 2024 that falls way below the Department of Financial Regulation's recommended range. And then its CEO said the Green Mountain Care Board underfunded Blue Cross premiums for more than a decade, which is what contributed to the insurer's financial problems in its estimation. So my question to you is, by cutting premiums to achieve affordability, at least in the short term, did the Green Mountain Care Board create a situation in which the state's largest insurer could become financially insolvent?
We don't fund anybody. And that's a really important distinction. Blue Cross's customers fund Blue Cross. We look at the affordability of healthcare insurance, and we make decisions based on a whole number of factors. One of them is consumer affordability. So you can't have it both ways, where Blue Cross has every dollar they ask for, UVM has every dollar they ask for, and every other hospital has every dollar they ask for. Every one of those entities will say they've been underfunded by the Green Mountain Care Board, which is really difficult for the public to hear, considering where their healthcare prices are. Frankly, I think it's a little bit of an excuse. We actually need to look a little bit deeper and not blame others and look at our problems and tackle them.
Sorry, you say that the public is pointing a finger at the Green Mountain Care Board? You're being used as a scapegoat?
No.
Or,
I mean, regulated entities, when they say that they're underfunded, it absolves you of responsibility for your operations. And I'm not saying Blue Cross, I'm just saying across all of our healthcare system.
Okay.
And where we are today, we need to not do that because we're in a real bind and we need to find solutions rather than explain away our challenges. So what I'm saying by that is that Blue Cross's insurance premiums have gone up 10%, 15%, 20% the last 3 years. It's really hard to see that be labeled as underfunding by Vermonters who are struggling to pay for health care. Now, at the same time, it is true that the Care Board did reduce some of Blue Cross's rate requests because we're trying to protect Vermonters from having to pay more and more money in health care insurance. And given a whole swarm of problems that have now come to be, including hospital budget overages, new drugs, drug prices going up, pharmaceutical use, a whole number of things have now led to Blue Cross's reserves being very, very low.
Where are we in the calendar of the year in terms of announcing premiums for the upcoming year?
That'll probably happen I think around May, first week in May. So we're about a month away from the requests being submitted to the Care Board. Okay.
So what are you all focused on right now? What's going on in these meetings that I get an email about every week?
So there's the public meetings we have almost every week, sometimes twice a week. And then we have a whole host of work groups and other things that we're working on that you're probably not getting notices of. The thing that's burning a lot of our time and space right now that we're focused on is immediate short-term sustainability and transformation of the healthcare system. Blue Cross has said, and we expect Blue Cross rate requests to be 15 to 20% again, maybe even higher. And what that does to our small business and economic growth, our demographics, people's family bank accounts, it's simply devastating. It's not acceptable. It's not sustainable. So if we're going to avoid a 15 or 20% rate increase, we have to reduce healthcare spending by several hundreds of millions of dollars really quickly. So it's a very tough spot to come up with hundreds of millions of dollars out of healthcare spending when the system, the healthcare providers that provide all this important care, are financially strained themselves. We're in a bind.
We talked about this recently with Mike Fisher, Vermont's chief healthcare advocate. He said something very similar to what you're saying right now. He also said that we're going to see additional rate increases next year, as you are also describing. Let's take a listen to how he put it.
What we've been doing is not working. And for those people who say, wow, last year's rate increases were way too much, brace yourselves. We're going to see the same increases next year, I believe. We haven't changed the way we're practicing, so why would we get a different result? So there are some tools that we think that the Green Mountain Care Board needs to use, particularly a provider rate setting tool. We see so much variation within the market and exorbitant prices at some Vermont hospitals. We're at a breaking point, and we have some pretty tough choices to make.
And if we don't change, Fisher went on to say that the market will make decisions for us, hospitals will close. First, what is the provider rate setting tool that he was speaking of?
In the Care Board statute, there's a number of authorities that we have. One of them is an ability to set how much providers get paid for certain services. The Care Board has never implemented that authority. It takes a period of time to set up rulemaking and stakeholder engagement to come up with a fair and appropriate way to do it. None of these tools are an overnight thing. They take time to do. But that's what that is, basically determining how much each person gets paid for what service.
And what do you think of Mike Fisher, the chief healthcare advocate for the state's estimation that the Green Mountain Care Board could be leveraging tools like that more?
I think he's right, but they do take time. And the other issue is when you reduce the prices, you will lose services. So when we reduce UVM's prices, we lost services. And we're going to lose services regardless. The market is already determining that the state is going to be losing healthcare services. So if we want to drive down that insurance premium, we're going to have to recognize that there's going to be some painful choices along the way. You can't have it both ways, where you have the status quo with 14 hospitals with a full set of services they currently provide and every other service around the hospitals and not have large rate increases. So we're at that inflection point where those are the painful decisions we need to make. I agree with Mike Fisher. We do need to lower the hospital prices, some hospital prices very, very significantly. But you have to do it in a way that isn't too disruptive to care. If you take out 10, 20%, 30% of a hospital's price overnight, that has consequences. And you need to balance all of those considerations when you do it. But we are in a crisis situation.
Let's pause here. When we come back, we have gotten a couple listener questions about those price differences at hospitals across the state that I want to ask you about. We're speaking with the chair of the Green Mountain Care Board, Owen Foster. If you have questions for him, you can call in at 800-639-2211 or email Vermont Edition at vermontpublic.org. Stay with us. Welcome back to Vermont Edition. I'm Michaela Lafrac. Today on the show, we're talking about the rising costs of healthcare in Vermont and the tenuous financial state of many rural hospitals here. Our guest is Owen Foster, the chair of the Green Mountain Care Board, and we're hoping to hear from you this hour. You can call in at 800-639-2211 or send an email to Vermont Edition at vermontpublic.org. Owen, this is a tough conversation to have. I can see we're in the studio together here, and I hope you don't mind me sharing that this is physically affecting you to talk about this work.
Yeah, it's painful to know what's coming and the difficulty it puts on Vermonters. There's no question.
Yeah. You have a tough road ahead.
We all do.
Yeah. So it sounds like hospitals, you're pretty sure, are going to close, or facilities will close across the state. That's what I'm reading from what you've been saying.
We're hyper concerned that that's going to be the outcome. When you're the choices are really, are we going to have these giant rate increases? Or are we going to have service line changes? The goal of the Care Board's work in the Oliver Wyman report was to avoid that outcome. But with some of the federal changes that are on the horizon, our timelines may have been pushed up pretty significantly. And that means you're making these decisions in a much more compressed time period, and they're very tough. So if you look at the Oliver Wyman report, I pulled a couple pages here to get the numbers right, but they predicted over a 5-year period, we would require $700 million to break even if we have a 3.5% revenue increase. So even with a projected 3.5% revenue increase this year, we're looking at a 20% potential rate increase to commercially insured Vermonters.
Wow.
So even at that level, we're going to be about $700 million short of break even for our current system. The projections are that we would have hospital margins by 2028. 13 of the 14 hospitals would be between minus 1.5 and minus 14.4% negative margins. That won't work. Last year, we had 6 hospitals with less than 100 days cash on hand and 6 hospitals with negative operating margins. It won't work. And that's before we had any potential federal changes, which could be several $100 million on top.
So let me just explain a couple of things here for listeners who might not have been following this. You've mentioned the Oliver Wyman report. So that came out last fall. It was a state-mandated report about the state of Vermont's hospitals, and it made headlines. It said that without some massive subsidies and changes, Vermont's hospitals could shut down. We got a lot of emails ahead of today's show with concern about that. And then there's what's going on at the federal level. Yeah, could you explain? We have been trying our best here at Vermont Edition to explain exactly how these changes to the federal system could affect us on the ground in Vermont. Could you try to break that down for us? I know you've had your head on it these past couple of weeks, and things are changing so quickly.
Well, so it's a really difficult operating environment because there's a number of things that are on the table from the feds that they're looking at and evaluating from their perspective as to whether or not they should be implemented. So which of those options are going to be chosen, if any, and then also to what degree and when is all unknown. But what you're looking at is seriously several hundreds of millions of dollars out of our healthcare system. And I'll give you just a couple examples. So one is we have enhanced subsidies on our QHP, our qualified health plans. So those are extremely expensive. For a family of 4 Platinum, you're looking at over $50,000 a year in premium costs. A 20% increase is another $10,000, almost $1,000 a month in premium increase. A huge number of people on our exchange, fortunately, have subsidies, and those subsidies drive down how much you actually pay. One of the things that's on the table are these enhanced subsidies that are set to sunset and expire at the end of this year. If just that change happens, it's $65 million, approximately $65 million hit to Vermonters. So that will mean people go off health insurance or they buy down health insurance or they can't have health insurance. And that has huge, huge impacts for our families.
Wow.
Yeah. On top of that, there's evaluation and consideration being done about the Medicaid rates, how much the feds contribute to Medicaid. Those could also be potentially hundreds of millions of dollars. If those go away, I mean, we have a huge hole in how we pay for health care and what we can afford.
Yeah.
So we have this sort of a 3-pronged problem. One, we have some of the highest healthcare costs in the country. They're going up the fastest. And everything we're paying all of our money to, not everything, but a huge amount of it is in financial disarray and challenge. All those hospitals I mentioned, Blue Cross, Blue Shield, a number of long-term care, mental health, DAs, everybody. So there's really nowhere to go. And then on top of that, you have these potential federal changes. So I think where we're at right now is we really need to come together and find the best choices we can, given these realities. In Vermont, sometimes we kick the can down the road a little too long. And in my view, we've done that in healthcare and we've done it in education. And then the problem gets harder and more intractable when we have to deal with it. But when we have to deal with it, we often come together and find solutions. And that's where we are now. We need to make the best choices we can with the realities we have in front of us.
So we were talking a bit about Medicaid, and we got a question about that from Richard, who's in McIndoe Falls. And he's really worried about these Medicaid cuts and how they could affect FQHCs, federally qualified health centers, which are in serious financial trouble. And many Vermonters rely on, especially if they're not close to a major hospital center like at Dartmouth or UVM. Could you talk us through how these federal cuts could affect these health centers here in Vermont?
So we don't know which ones will be implemented, and there's also HRSA, which provides funding to FQHCs. What we do know is a number of our FQHCs are in really acute financial distress. Little Rivers, Lamoille, community health centers at Burlington, they provide really critical primary care access here in the state. And their financial projections and line is very, very steeply negative. Any change in the amount of money they receive will be very impactful to their ability to sustain operations. So if it's a cut from commercial because Blue Cross is in financial trouble, if it's an increase in their healthcare costs, any cost increase, any of these things, when you're that low on reserves and your margins are negative, is very disruptive and potentially changes your operations.
We're speaking with the head of the Green Mountain Care Board, Owen Foster. Let's take a couple calls here. We have David on the line in Poultney. David, you're on the air. Go ahead.
Oh, thank you. I'm always hearing that the hospitals are expected to cut administrative costs, but it's never mentioned that Blue Cross Blue Shield is 100% administrative costs. And the Green Mountain Care Board, all of that expense is 100% administrative costs. Don't we have too much administrative costs outside of the hospitals that are actually providing care?
Thanks, David.
Yes, I think we do have too much administrative costs across the state in healthcare, whether it's at hospitals or elsewhere. I would correct, I don't think that Blue Cross is 100% administrative costs. I believe it's around 94% of their revenue goes to pay for claims. So I don't know if that's really counts as administrative costs. And yes, the care board, we don't provide any health care, of course. Our job is to try and balance the health care costs and affordability and sustainability. And we have to be responsible for our return on investment. We are an expensive organization like anyone else. And if you look at what we've done, we think that we've had a pretty positive impact on a very challenging situation. But I think your point's well taken. I think that's one thing we all need to look at is, can we across the board look at our administrative costs to save this money?
Anne is calling in from Williston. Anne, go ahead.
Hi, I have a couple points to make. One, UVM Medical Center is obviously the largest hospital in Vermont. We take a lot of Medicare, Medicaid patients. Our population is aging, and Medicare is just going to be more and more patients. And so the cost the money that they're giving to the hospital is very low compared to private insurances. Also, the Medicaid of New York we have. So many of my patients are from the New York side of the lake. The other thing I wanted to point out was the hospital is the largest employer in Vermont. So if people cannot afford they can't afford to live here already. So if you shut down the money to UVM Medical Center and its subsidiaries, then you're going to shut down salaries to the people who are doing the work on the ground. And people are going to move away from Vermont, and it's just going to get worse.
Thank you, Anne. So it sounds like Anne is feeling like UVM Medical Center is perhaps having some fingers pointed at it that could put it in financial distress. Is that what you're hearing, Owen?
So I think there's 2 points. I think Anne made the point that, or said that Medicare doesn't pay enough. We don't agree with that, actually. As our state ages, you have to be able to run an efficient operation on Medicare rates. And a lot of hospitals do run efficiently and break even on Medicare. Medicare should be paying about 98 to 100-ish% of your costs. So if you're not, you need to look at your operations and make sure that you are. Because as we age, that commercial pool will get smaller and you can't tap that market. I agree with Anne that people will move away if they don't have quality health care that they have access to. They also move away when businesses have a 20% rate increase every single year and they can't afford to hire people.
Thank you, Ann, for calling in. And we also have Bill in Waterbury on the line with us. Bill, what's your question or comment today?
Yeah, it's also about Medicare, and I really appreciate the job that the Green Mountain Care Board is trying to do, and the complexity of it is just amazing. But, you know, I was fortunate enough that I was able to retire a couple of years before I turned 65. I continued on my own to pay for the MVP bronze plan that my employer had been providing for me. So for my wife and I, that was about $1,800 a month, and we had like a $14,000 out-of-pocket maximum that we faced. Fortunately, we're healthy, but now my wife and I both are on Medicare, and now we pay like $185 a month for a Medicare Advantage plan through Blue Cross Blue Shield, and we pay the federal government. I'm sure they're paying money to Blue Cross to pay for us, but I was able to afford to pay, you know, I didn't like paying $1,500 a month for my wife and I, but I was able to afford it. Now I'm paying $185 a month each, and the benefits, I mean, we get a thing in the mail that says, oh, now you can submit up to $50 a month each, $50 a quarter each for over-the-counter things that they'll send to us. So it seems like somebody's losing some money here somehow, and I'm grateful. It's a great deal for me, but I'm not sure how it does a good deed for the state of Vermont.
Thanks, Bill, and thanks for breaking down your cost too for us to use as an example. Have you heard this before, Owen?
Yeah, I mean every person and family has a different financial situation. And for some people, Medicare is a really reasonable deal and they can afford it no problem. And for others, it's really a pain point and difficult. So I appreciate Bill's perspective.
But he's saying that he was able to pay more and is now getting he's qualifies for lots of benefits that, you know, his family might not necessarily need. It's not a financial necessity to get this type of support. Does that point to a larger issue with the Medicare system?
I'm not really sure. I don't know what plan he's on exactly or what the benefits are. I mean, some people really need those benefits. There's no benefit plan that will be perfectly tailored to exactly what you need, and maybe Bill or he may need those things. So it's hard to say.
Okay. Well, I want to go back to an issue we were talking about before, which was the difference in costs between hospitals in Vermont for generally the same type of care. So we got a couple questions about this, including one from Kip, who's a certified nurse midwife. And I haven't been able to fact check these numbers, but Kip says that at UVMMC, obstetrics care is about $17,000. At Copley Hospital in Morrisville, it's about $6,700 for essentially the same care. And Kip believes that bringing these rates marginally closer together would help rural Vermonters continue to access quality OB care and not increase healthcare costs for all and start to minimize UVM's revenue overages. First, can you explain why the two costs of care are so vastly different?
I'm not sure exactly what numbers Kip's looking at. I mean, there's a charge master, and then they have negotiated rates with hundreds of different insurers potentially. So exactly what those numbers are.
But broadly.
There will always be disparity between a particular service CPT code for any particular hospital. What we look at is sort of more macro data that compares hospital commercial prices. The source we generally use is called RAND. It's an independent study that looks at this. So we look at it at a higher level. And it is true that some Vermont hospitals are extremely high priced while others are more reasonable. In our regulatory decisions the last 3 years, we have been driving down the price of the higher priced hospitals and allowing for more increases at the lower ones. So Copley, I think they had about a 15% rate increase last year. They were, on a Vermont relative basis, more affordable. Northwestern, on a relative basis in Vermont, they were more affordable. UVM was more expensive. You've seen their rates actually go down in recent years. So we do consider that, and that does have an impact on some of our decisions. Within those decisions, though, the hospital has a lot of discretion as to where they allocate that rate, as to what service lines. So you will find disparity, but what we're looking at is a high level, how expensive are you?
So there is a role that the hospital boards themselves are playing in setting those costs.
I believe it'd generally be their management who makes those decisions and negotiates those rates with the insurance companies.
Okay. Because we got a related question about maternal care from a listener named Tracy. She's planning to deliver a baby at Copley's Birthing Center next month and is really worried that it's going to close down. And she writes, I'm concerned that the financial crisis of healthcare in Vermont will be exacerbated by funneling all births, including low-risk births, to large hospitals such as UVMMC. How do we make sure small hospitals and their decision makers have all the accurate information they need to make informed decisions for the good of patient care and the financial health of Vermont's healthcare system as a whole?
Yeah, well, it is their management and the board's fiduciary responsibilities to have that information and understand that information. So I presume that they all do. It's not simply, though, are they more affordable for this service or that service? You also have to look at the volume and the safety and the quality of the work that's being done. If a hospital has lower prices but doesn't have sufficient volumes, should you keep the service? Because it might be more expensive as you need 4 or 5 doctors and all the nursing staff and the facilities to deliver that care. So you want it local. We all want everything local, but the reality might be that it's not sustainable given the volume of care that they may have. If somebody's doing 5 knee replacements a year, it might be cheaper, but do you really want it there? Because it's going to take a lot of infrastructure costs to provide that service.
Let's take one more caller here. We have Silas in Rutland on the line. Silas, you're on the air. Go ahead.
Yeah, hello. I have a background in many years in insurance and studying, Standard & Poor's, AM Best, et cetera. And in 2022, I saw trends occurring, which you were seeing in numbers, which was alarming. And I actually went to the Department of Financial Regulation to get their assistance to track down more numbers. And the numbers have trended continuously. I brought this up at the meeting of the Green Mountain Care Board and the consultant at the Rutland Hospital at the end of July of last year, and asked about the future. He had a great plan, and
I'm so sorry, Silas. We only have a little bit more time with Owen Foster. I'm wondering if you have a question for him or a specific point to make.
I'm getting there. But I was brought up preventive care, and the CEO of the hospital told me there was a wall. The hospitals couldn't initiate preventive care programs because of the physicians. That's a physician duty versus the hospital acute care duties, and that they couldn't do a preventive care program, which I found to be astounding. Mm-hmm. The other thing that's on top of this is the old age of the population in Vermont, and the smoker costs, which Vermont Edition covered a number of years ago as being horrendous. Mm-hmm. And so the hospitals are getting hit with this, and thus the insurance companies. Okay. And it's in the numbers. Thank you.
Thank you, Silas. There was a lot in there, and I'm wondering if there was anything that you pulled out from Silas's assessment. It sounds like he's been watching trends very closely and has sort of projected that costs are going to go up.
He's right about that. I didn't follow the hospitals aren't allowed to do preventative services. I think actually quite a few engage very much, and we're really leaning on hospitals to do that. It's critical.
Okay. Well, thank you, Silas, for calling in. And to our other callers, I apologize we don't have time to get to more. I have one more question for you, Owen, before we have to wrap up here. And it's about Vermont's all-payer model, which its goal is to try to reduce healthcare costs, of course. And there's this organization here that some folks might have heard of called One Care Vermont, which maintains these contracts with public and private insurers. It's shutting down this year, and Vermont's been accepted into a new federal program called AHEAD, and I believe we have until June to decide whether or not to participate in it. Is that right? And is this the board's decision?
Close to correct. It's 3 signatories, the governor, the secretary of AHS, and the care board have to sign on to it. the three parties have already signed on to a state agreement. That was before the new administration, and the new administration has evaluated it, and they want some changes to the model. It was unclear at the time we voted. It's very difficult to predict the future as to whether or not it would be additional money. If you look back at the all-payer model, it was hoped and anticipated that it would drive down healthcare costs and increase preventative care and move costs out of hospitals. It didn't happen. It didn't work. It has not worked for any number of reasons. This model has similar goals with a different methodology to achieve it. Whether or not it goes forward, I think, is still something that we need to evaluate, so we can pull out at any time without any repercussions, essentially. So we're going to be discussing and negotiating with the new federal administration what they would like to see different, and we will evaluate whether or not it is something that is a positive to our healthcare system. But we're not going to go into a model and do a model that's extremely expensive, extremely burdensome, and risky unless we have a degree of comfort that it will actually help our situation. We don't have any risk tolerance or slack in our healthcare system right now. So that'll be another difficult decision we all have to make.
Owen Foster, chair of the Green Mountain Care Board, thank you so much for your time today and your work on this very difficult problem.
Thank you for having me.
Coming up on Vermont Edition, we are going to get an update on local employers' efforts to diversify the hiring pool and help new BIPOC employees make local connections. Don't go anywhere. Welcome back to Vermont Edition. I'm Michaela Lafrac. Vermont is the second whitest state in the United States, after our northern New England pal, Maine. According to the United States Census Bureau, Vermont's minority population did grow slightly between 2010 and 2020. The state's population went from 1.5% Hispanic to 2.4%, for example, and 1% Black to 1.4%. Now, getting diverse groups of people to remain in the state can be a challenge. A local organization, the Vermont Professionals of Color Network, has stepped in to help. Late last year, it launched a program to help businesses recruit and retain people of color from out of state. It's called the Newcomer Nexus program. Tino Rutanhira is the executive director and co-founder of the Vermont Professionals of Color Network. Tino, it's so nice to see you again.
Thank you, Michaela. Good to be back.
And I should also note before we chat that one of the co-founders of the Vermont Professionals of Color Network, Wei Wong, is on Vermont Public's board of directors. Tino, let's start with your own experiences, which no doubt have informed this program that we're talking about today. When you moved to Vermont, was it hard to make connections with other people of color here? And how important were those connections to you for feeling a sense of home?
It was incredibly difficult. And in fact, it is one of the reasons why I started this organization was to find other professionals, other folks of color in the community that were having the same experiences that I was, being the only person of color in a meeting or being the head of a department in an organization, but you're a person of color and there's no other peers around you. So it was a very difficult experience as I started moving and navigating through my career, and I really felt the need for creating community and not feeling so isolated and lonely.
And as the head of the Vermont Professionals of Color Network, I imagine that you talk pretty regularly with employers, both large and small, who are trying to figure out how to hire talent to their organizations. What challenges have you heard from them?
Yeah, I talk to them all the time, and some of the main challenges that they have is the recognition that Vermont not just faces a recruitment problem, it faces a retention problem. And we know through the data, for example, that Vermont has a 2.5% unemployment rate. And so with over 20,000 open jobs, even if every single unemployed Vermonter got a job, there would still be over 15,000 unfilled jobs. So what do we do with that? And how do we now find talent when Vermont has such a talent pool? And so organizations are starting to look outside the boundaries of the state and trying to figure out, like, how do we solve some of the challenges?
Yeah. So we were just talking earlier in the show about the healthcare industry. I'm curious if you've worked with hospitals, or say the UVM Health Network, which is the largest employer in the state, or other healthcare organizations on recruiting.
Yes, absolutely. In fact, maybe that's how I can transition into how the Newcomer Nexus program came about. It was inspired by a gentleman whose name is Gary Scott, who is a personal friend of mine. He came here from Dallas, African-American man. He came to work for the UVM Health Network. And unfortunately, during the time when I met him, he was actually about to leave Vermont because he felt lonely and isolated. He didn't know where the Black community was. And so fast forward a couple of years now, Gary's one of my closest friends. And now you can imagine the conversation that might have happened when Gary, who's a senior executive for the health network, came to Vermont. And lots of people probably in his friend network were wondering, like, where's Gary? Gary's in Vermont. Vermont? What's Gary doing in Vermont? Like, when did Gary move to Canada? Sort of thing. And yet now, fast forward a couple of years, Gary has now been posting stuff on his LinkedIn and his Instagram of all the positive experiences that Gary's been having about life in Vermont. And in fact, Gary's son now attends Champlain College. And, so now I've actually met some of his friends who've moved up who've come to visit him here in Vermont. And those people, you can imagine now, as they see maybe jobs on LinkedIn or Indeed that might be from Ben & Jerry's or UVM the college or the medical center, they might now have a different take on what Vermont is like because they start to think like, I could do Vermont because they've experienced all the good things that Gary has now experienced as a person of color living in Vermont. And so essentially, that's the sort of genesis of the idea that came to me about, we need to create a concierge program that allows folks of color to feel welcome and connected when they come here. And so the Newcomer Nexus program does two things. One, it's a recruitment tool when organizations are looking to expand their workforce and are looking outside the borders of the state. They then start to look for candidates. And if that candidate is a person of color, we come in and have a conversation with that person when the part of the interview process is like, why don't you uproot your family and move to the second whitest state in the country? That's a difficult conversation for a person of color to actually now start to think about. But where we come in is we're contracted with the employer to talk to them about what life is like in Vermont as a person of color. What are the real challenges that they will face when they get here, but also why have some of us chosen to live here for 10, 15, 20 years and really kind of make the soft sell to them about why Vermont. And so we do that as part of the Newcomer Nexus program as the recruitment tool of this. And then in terms of the retention piece, when that person, if we're successful to move them from Tampa or Pittsburgh or wherever, and normally what happens is they just dropped in the middle of Colchester on a wet, cold Thursday in February, and hey, we'll see you at work on Monday. And yet we get surprised when 6 months down the line, this person is wondering like, why am I still here? I'm lonely. Like, I hate it here. Where are my people of color? Like, where can I get ethnic foods? Where can I get my hair braided? All of these conversations, all these thoughts. As an employer, you're not thinking about that. You're thinking about how's their orientation going? Do they have their laptop? All of that stuff. You're thinking about the stuff that's happening between 9 a.m. and 5 p.m. You're not thinking about the stuff that happens when this person goes home. And so as part of our retention part of this whole process is that we then assign an ambassador to that individual. And that ambassador sticks with that person for 3 months. They take them out to networking events that we hold. They take them out to things like the Flynn or wherever there might be stuff going on within the community. They show them where they get their hair braided. They maybe show them where they can get halal food or where the houses of worship are. They explain to them why we put our windshield wipers up when it snows.
It's like the adult professional version of like your buddy in school if you started at a new school.
Exactly. So that then fast forward 4 years, like Gary's been here, he is now part of the disciples that we send out into the nations to preach the good gospel about Vermont and to really tell the reason why some folks of color like me have chosen to call Vermont home.
So tell us about getting this program off the ground. Have you started matching people yet?
Yes, we actually have organizations that have partnered with us. The UVM Health Network, for example, we've got 2 people that are currently matched with ambassadors, as well as the University of Vermont Medical Center. We actually started off with a small program with their psychology department, and I met a woman by the name of Courtney Fleischer, who is an incredible ally. In fact, I won't even call her an ally. She's a co-conspirator for us because, like, sometimes when I use the word ally is like, how can I help you? Courtney is a true co-conspirator. She's in the trenches with the rest of us trying to make a case for how do we really make Vermont feel like home for people of color. And so what Courtney did was she connected with me on the Newcomer Nexus program and has implemented it for the residents that are coming to Vermont to do their residency. And so you can imagine that they've had struggles and challenges when people finish their residencies. A lot of them leave because they haven't really found Vermont to be a place that they want to call home. And so a year ago, I partnered with Courtney. We did our song and dance with her department, and then we actually ended up implementing Newcomer Nexus for the psychology services department. Fast forward to today, we now have 6 departments within UVM Medical Center that have all signed up to do the Newcomer Nexus program with us, so that as they get resident doctors who are then going to be like working with the different folks of color that now live in Vermont and have always been seen by white doctors who don't always know what their medical conditions are in terms of like from a race perspective. Now you have these resident doctors of color that are now coming into UVM Medical Center and are going to be supported by our program. And then hopefully over time, some of them do decide to stay because they've had such a positive experience in Vermont.
So how do people get involved? Particularly, say, if you're listening right now, you're a person of color and, you don't work with one of the organizations, the partner organizations that you just mentioned, but are saying, hey, I could really benefit from having that type of connection with a Vermonter who has lived in this state a long time or their whole life. Can they get involved?
Yes, they can. It is a fee-for-service model. We do try to make money out of this, but not for the organization, but in order to pay the ambassadors, because we want the ambassadors to be able to take folks to the Flynn or to take them out for dinner. And so we would, if somebody is interested, please get in touch with us. We will work with them to talk to their employer and then ensure that the employer is participating in this, because from an employer's perspective, you don't want to lose an employee just because you didn't want to spend an extra $1,000 to $2,000, right? And so for us, it's critically important that we work together with employers. And we're also we're trying to get the state to contribute towards this, because I believe that, for example, my dentist, who's maybe like a 5-person practice, if they found a person of color from outside the state to come and be an oral hygienist or the dentist themselves, that shouldn't be a prohibitor for them to be able to go through this process, because that investment in that individual is a lot of money, and we want to make sure that they're successful. So even for small practices or small organizations, we would like the state to work with us to create opportunities to subsidize this program so that it costs them less.
Well, you preempted my next question, Tino, which was, are there any more large-scale, perhaps less high-touch models or ways of investing state resources to help with these recruitment and retention efforts while you and your organization are working with people one-on-one?
Yeah, I mean, we would like to continue working with the legislative branch as well as the executive branch of the state to continue to see, like, how do we create an environment where we are able to push these services forward, because at the end of the day, it's new people to Vermont that are going to spread the good news about Vermont. People won't believe me because I've lived here for 20 years, but if it's new people that come here and really have a good experience, that is how we get new and younger people relocating to Vermont to shoulder the burden of responsibility and to grow the economy as well as the population of Vermont.
Tino Rutenhira is the co-founder and executive director of the Vermont Professionals of Color Network. Tino, thanks so much for your time today.
Michaela, thank you so much for having me.
And if you enjoyed the interviews that you just heard and the fact that anyone can listen to Vermont Edition for free, consider making a gift to Vermont Public. It's our spring membership drive, and your dollars directly support programs like this one. You can give on the Vermont Public app or online at vermontpublic.org. And thank you from our whole team. We do what we do because of you. Today's show was directed by Aaliyah Papes. Our managing producer is John Ahrens, and our producers are Andrea Lorian and Daniela Fierro. Anna Berg is our intern, and our call screener is Rick Barrett. Our theme music was composed by Myra Flynn. I'm Michaela Lafrac. Thank you so much for listening, and we will catch up again soon.
It's 12:59. Stay with us for Here and Now. That's next. Vermont Public